Welcome back to Part 7 of our masterclass on mastering myocardial infarction ICD-10-CM coding. I'm Harshal, and today we're jumping right into one of the most absolutely crucial skills in your toolkit, translating that complex, life-or-death cardiac documentation into precise alphanumeric codes. You already know that getting this right is what prevents claim denials and protects revenue integrity, so let's just get right into it.
Okay, here's our roadmap for today. We're going to cover the anatomy of an MI, the Type 1 MI hierarchy, site-specific codes, NSTEMI and default rules, and then wrap it all up with a real-world coding scenario.
Section 1, Anatomy of an MI. Because let's be real, you can't master the code book if you don't master the human body first.
Let's talk about the major coronary arteries. We've got the left anterior descending, or LAD, the circumflex artery, and the right coronary artery, the RCA. Why does this matter to us? Well, blockages in these specific vessels are exactly what dictate our highly specific code choices. A blockage in the LAD behaves completely differently clinically than a blockage in the RCA. ICD-10-CM requires us to capture that exact clinical story so our claims reflect the true underlying complexity of care.
Moving right along to Section Q, the Type 1 MI hierarchy. Let's shift our focus from the physical heart straight into the coding rules.
So, the crucial point here is understanding the baseline rule for category I21, which is strictly dedicated to Type 1 acute myocardial infarctions. Here is the golden rule you absolutely need to memorize. An acute MI is defined by a stated duration of 4 weeks, or exactly 28 days, or less, from onset. If the care happens within that exact 28-day window from the initial event, it's considered a current acute Type 1 MI. Nailing this timeline down, that's literally the bedrock of accurate cardiology coding.
Section 3, Site-Specific Codes. Now we map the affected wall straight to the code itself. Let's break down the anterior wall STEMI codes. If the documentation states a STEMI involving the left main coronary artery, your code is I21.01. If it's the left anterior descending, the LAD, that maps precisely to I21.02. And for other coronary arteries of the anterior wall, things like anteroapical or anterolateral, you're going to select I21.09. Matching these up perfectly is what guarantees airtight revenue integrity.
Let's see how this builds for the inferior wall. For an inferior wall STEMI involving the right coronary artery, the RCA, the code is I21.11. But what about the left circumflex artery? Well, that actually falls under other sites and maps to I21.21. Any other specified sites like a true posterior or posterolateral STEMI, those drop right into I21.29. As you can see, the real power and specificity is all in that fourth and fifth character.
Section 4, NSTEMI and default rules. Because, what happens when the clinical picture isn't painted perfectly for us?
Now, what's really interesting here is how the tabular list resolves a very common coding trap. If your physician documents a STEMI or a transmural MI, but they just fail to document the specific site, your default code is I21.3. However, if they document an NSTEMI, an acute subendocardial MI, or a non-Q-wave MI, you immediately go to I21.4. You do not code an NSTEMI based on the anatomical site. It has its own dedicated code. A misunderstanding right here? That leads to immediate claim denials, for sure.
We absolutely have to talk about default and instructional notes, because this is where coders lose easy ground. If the chart just says acute MI and it's completely unspecified, I21.9 is your default. But listen to me carefully here. Never, ever ignore your tabular instructional notes. You are strictly mandated to use additional codes for tobacco use, dependence, or exposure. You also have to use an additional code, Z92.82, if the patient is status post TPA administration within 24 hours prior to admission. And finally, always check your excludes 2 notes. For example, an old MI, code I25.2, well, that can be coded alongside a current MI if it has significance for the current episode of care. The takeaway here? Don't leave these secondary codes off your claims.
Section 5, Coding Scenario. Theory is great, but application is the whole shebang. Let's simulate reviewing a complex chart.
Okay, picture this real-world scenario pulled straight from the coding clinic. A patient with severe chest pain is admitted to community hospital and diagnosed with an acute anterolateral wall STEMI. 2 days later, they're transferred to University Hospital for an angioplasty. After 3 days there, they're transferred back to community hospital to recover for 4 more days. Think about the rules we just went over. So what exactly is the code for the first admission, the transfer admission, and the return transfer admission?
The answer might surprise a novice, but definitely not you guys. The principal diagnosis for all three admissions is exactly the same, I21.09. Why is that? Well, because the acute anterolateral wall STEMI is an other coronary artery of the anterior wall, mapping to I21.09. And since all of these transfers and admissions happen well within that strict 4-week or exactly 28-day time frame from the initial episode, the acute MI remains the principal diagnosis for every single one of those encounters. It's like a giant puzzle coming perfectly together. That rule perfectly brings us to the end of today's explainer. Let's do a really quick recap to ensure your revenue cycle stays absolutely flawless. To accurately code a type 1 MI, you've got to master the clinical anatomy of the coronary arteries. You must rigorously follow the 28-day rule for category I21. You need to know your defaults for unspecified STEMIs and NSTEMIs, and you must always check your instructional notes for tobacco use and TPA administration. Master the anatomy, follow the 4-week rule, and always check those instructional notes. But post this thought to yourself: if this patient returns on day 30 with a completely new infarction, do you know how the rules completely flip? We're going to tackle exactly that in Part 8, Decode Healthcare with Harshal.